Oh, we're ready to go. Right, I think we're ready to go. Hello, everyone. Who's the most nervous? Me. Probably Mark.
I think it might be me.
Take a deep breath. Hi there. I'm Deb Howe. I don't think this is working. Bit louder. Hi, can you hear that? I'm Deb Howe, and I'm the Acting Commissioner of the Mental Health Commission of New South Wales. So great to see everyone here tonight. It's very exciting. And it is very exciting. We're going to be hearing about something I think that's going to really challenge us when Mark talks to us, and so does Annie, and so does Karen. And we've got online people as well. So I'll just officially start by welcoming us all to country. I'd like to acknowledge that we're meeting today on the lands of the Gadigal people and acknowledge the traditional owners and custodians of the land. We celebrate the diversity of Aboriginal people and their ongoing culture, connection, and lands and water. And I pay my respects to elders past, present, and any emerging leaders here today. I'd now like to invite Paul Fung, Dr. Paul Fung, who's one of our Deputy Commissioners, up here to do an acknowledgement to lived experience.
And so on behalf of the Commission, we'd like to acknowledge those who have lived experience here with us today and online, lived experience of mental health issues and distress, not just for them, but also their carers, their families and their support networks. We at the Commission really take quite seriously amplifying the voice of lived experience. We respect and acknowledge that it comes with a wealth of experience, not just individually, but together as a group. So we want to do our best and do our bit in helping people live free from stigma and discrimination.
Thank you. So I'm just going to talk briefly through the agenda before we do the introductions. So we're lucky enough tonight to have a number of experts to discuss the process of deprescribing psychotropic medication for people with lived experience of mental health problems, mental illness, mental health. We'll start by hearing from Mark Horowitz, who is the author of the co-author, Mark, of the Maudsley Deprescribing Guidelines. And then we'll hear from Professor Catherine Wallace, who's online, who'll give us an overview of antidepressant deprescribing in Australia and of deprescribing using a tapering protocol. And then we move to the practice part of the session. And we have Dr. Karen Spielman here, who'll talk about the role of GPs in transferring the Maudsley Deprescribing Guidelines into practice. It's going to be great to hear. And then we'll hear from Annie. Really, really looking forward to hearing from you, Annie. No pressure. It's no pressure. But she'll describe the lived experience, I guess, of coming off medication and how that was for you. So, and acknowledge that, when we are talking about our lived and living experience, it can be sort of a time where it's get a little bit emotional. So we're here with you. Okay. Thank you for sharing your wisdom with us tonight. I really appreciate it. I'm sure there's going to be, there's also many questions, I think, during the session. So we have 30 minutes for you to ask your questions. So you put them into the chat. And for those of us in the room, you'll be able to put your hand up and Paul will be, I think, emceeing the questions. For those who are here in person, can you please hold your questions to the end? Okay. And I needed to raise an issue. There are CPD points for this session. So for those who wish to claim continuous professional development points at the end of the session, you'll be able to describe the neurobiology of psychotropic withdrawal, outline the risks associated with psychotropic withdrawal, compare symptoms of withdrawal with the relapse of psychiatric condition, and identify when, why, and whom to stop antidepressants and benzodiazepine medication. Okay, so now we're going to get into the introductions. I think there's another thing. If you are dialing in online, please add your name, email address, and RACGP identity number to the Q&A. Okay, so thank you for that. Okay, Mark, I'm going to be introducing you now. So it's we're delighted to have one of the co-authors of these Maudsley Deprescribing Guidelines. Amazing achievement. So well done. And he's Australian, so even better. So currently working and living in London, and a clinical research fellow in the National Health Service and an honorary clinical fellow at the University College of London.
Yes.
And you have a PhD in neurobiology of depression and pharmacology of antidepressants at the Institute of Psychiatry, Psychology and Neuroscience at King's College London. This is really impressive, like really, really impressive. So while working on your PhD, you received 2 prizes from the British Association of Psychopharmacology, one for your PhD work and one for the public communication. So warmly welcome you. I'm really looking forward to what you've got to say.
Okay. Thanks very much. Thank you for that kind introduction. Thanks for having me to speak. Does my microphone work well enough as it is? Yes. Okay. All right. So I'm going to talk. I'm going to give a 25-minute talk in 21 minutes. I'm going to talk about how the withdrawal effects people get coming off psychiatric drugs and how to avoid them by coming off more carefully. I'm going to focus a lot on antidepressants because they're so widely used, but a lot of what I'm talking about relates to benzodiazepines, sleeping tablets, and other drugs like gabapentinoids. So the context for the talk is in Australia, about 1 in 7 people, or 1 in 6 adults are on an antidepressant, about 3.5 million people. The average duration of use is about 4 years. They're mostly prescribed to people with mild to moderate conditions. And most guidelines recommend that people are only on them for 6 to 12 months. So we have an increasing population of people that are on them for much longer than guidelines recommend. This is a story about Australia and the UK. I'm trying to incite a bit of competition like in the cricket between the two countries because there's been a lot of progress on this topic in the UK and not as much in Australia. For the last couple of decades, authoritative guidelines like the Therapeutic Guidelines or the College of Psychiatry have said that discontinuation symptoms, a euphemism for withdrawal symptoms from antidepressants, are usually mild and last 1 or 2 weeks. This description actually comes from studies done by drug companies in the 1990s of people who had been on the drugs for 8 to 12 weeks. And it is true that after that, a few weeks, people mostly have mild and brief symptoms. But as we'll see, for people who are on these drugs for longer, years or decades, most symptoms are not mild and brief. So this is a little bit to me like a car company crashing its car into a wall at 5 kilometers an hour and saying it's safe and ignoring the fact that people are driving around at 60 kilometers an hour. That's unfortunately informed medical practice for the last couple of decades. So slightly small writing here. Along with this, the guidelines recommend the following way to stop psychiatric medications, including antidepressants. They recommend to reduce the dose by about half for a couple of weeks, reduce by half again for a couple of weeks, and then stop. Similar guidance from the Therapeutic Guidelines and the Royal College of Psychiatrists. This was the guidance in the UK up until a couple of years ago when it was updated. That guidance was based on a single study in which drugs were stopped abruptly and the withdrawal effects were thought too severe. So the committee at the time decided that 4 weeks was a reasonable time. In other words, this was based on no research. It was just the consensus of a group of doctors 20 years ago. In fact, a recent trial in the UK has shown that more than half of people can't stop their medications in this way. In fact, the study looked at an even slower way of stopping, which means that up to a couple of millions of Australians may be trapped on their medication because they can't get off with current guidance. That's a potentially big issue. The consequence of this is that many people leave the advice of their doctors and go to online forums where they find people that have had trouble coming off their drugs in a similar way, and they get advice that they should come off much quicker, much more slowly. The sort of advice they get given is come off at about 10% of your dose every month. So it gets smaller and smaller and can take months or years. And many people are on these websites because they've been told by their doctors when they've presented with issues coming off the drugs that they, so I'm trying to look at slides, the camera and the audience. And I'm sure I'll fail at all three, and I'll keep being reminded. I want to make sure that my bald spot is very present for people at home. People are the story that they tell again and again on these websites is, I tried to come off my drug. I had terrible symptoms. The doctor said there shouldn't be major troubles coming off these drugs, and therefore I must have relapsed, had a return of my anxiety or depression, and I put back on the drugs. But because they've had other symptoms like dizziness or headaches or brain zaps, they think this doesn't make sense, and they end up leaving medical care to go onto these websites. And we'll see by the end whether the advice on these websites or the advice from authorities is more useful for most patients. So antidepressant withdrawal syndrome is a collection of physiological symptoms that occur on stopping or reducing the dose of an antidepressant. They can manifest in either psychological or physical symptoms because these drugs affect so many different organ systems, the guts, the hormonal system, as well as the brain. Another point of misunderstanding is that withdrawal requires addiction. That's not the case. So antidepressants don't cause craving or compulsion. What happens is after long-term use, your brain adapts to the presence of the drug, and when you stop it, the brain misses the drug. That's often referred to as physical dependence, which is different from addiction. For example, I imagine most people in the audience will be physically dependent on caffeine. No one is injecting it, stealing from their neighbors to get more caffeine. But if you stop it, you'll get a withdrawal syndrome. And the same is true for antidepressants, not about withdrawal. There's a very long list of withdrawal symptoms from antidepressants, of which some are listed here. I'll just pick out a few. The mood symptoms, depressed mood, anxiety, irritability, tearfulness, suicidality, are the ones that cause the most confusion. We know that these are withdrawal symptoms from the drugs because they are found even in people that are given the drugs for reasons other than mental health problems. So in people given them for the menopause, for pain, or even in healthy volunteers, when they stop the drugs, they demonstrate these symptoms. There are sensory symptoms, a bit famous, are brain zaps, this little sense of shock through people's heads, or that their brain has been switched off for a second. A couple of the more serious effects are suicidality. So there's an increase in suicide attempts in the 2 weeks after stopping drugs that has been associated, that's been attributed to withdrawal itself because it's too soon for relapse. And another issue that's often overlooked is akathisia, which is the Greek word for can't keep still, which is recognized as a long-term side effect of antipsychotics, but can also occur in people coming off antidepressants and benzodiazepines. It involves people feeling full of terror, restless, pacing, and often highly suicidal. When they turn up to emergency departments or urgent clinics, they're often misdiagnosed as having agitated depression or mania or psychosis because most clinicians are unaware that coming off antidepressants can cause this. Duration of withdrawal symptoms. Another issue that comes up is people report having weeks or months of symptoms after stopping, and they're told by their doctor, this can't be the drug, it's out of your system, it must be something else, it must be a new psychiatric illness, a neurological problem. That is a misunderstanding of what causes withdrawal effects. It's not just the drug leaving the system, it's how long the system takes to readapt to the drug not being there. So we know that after people stop antidepressants, they have changes to their brain, to the serotonin system, and even the hormonal system that can last for months or years after stopping. So there are residual effects that explain why people can have months or years of symptoms after stopping. Very briefly, an analogy is, go into a loud concert, your eardrums become less sensitive to sound. If you leave the concert and go out onto the quiet street, your friends' voices sound muffled for a few minutes. It's actually a sound withdrawal syndrome. It takes a second for the sound to dissipate when you close the door. The reason why it takes a couple of minutes for people's voices to sound normal is because it takes that long for your eardrum to relax back to normal sensitivity. And the same is true for psychiatric drugs. It can take the brain months or years to go back to their normal pre-drug way of being or their factory settings. And that's why people can have symptoms that last months or years after stopping. So how common, severe, and long-lasting are these withdrawal symptoms? Systematic review done a few years ago, looking at all the studies in this area, found that about half of people have withdrawal effects on stopping, and 1 in 4 have severe problems on stopping. I think what's most interesting about this, if there's a pointer, is the graph, which shows there's a big difference based on how long you're on the drugs for. So this doesn't quite work. But on the left side of the graph, when you're on the drugs for a few months, most people don't have withdrawal effects. And if they do, they're mild, which is exactly where the drug companies did their studies and exactly what the guidelines are talking about. But once you move to the right-hand side of the graph, where people are on the drugs for 3 or 4 years, like the average user in Australia, most people are having withdrawal effects, that's the top line, and most people are saying those effects are moderately severe or severe, that's the bottom line. And so things are much more difficult for long-term users, which is where the real issue is. A recent study looked at the shorter-term users and found it was less common, really reiterating the findings of drug companies earlier on. I've already mentioned this briefly. A major issue is misdiagnosis of withdrawal effects as relapse. We surveyed 1,300 people out of the 180,000 people on these websites to ask them why were they there. And they were there mostly because they said my GP, my psychiatrist, my nurse misdiagnosed my withdrawal effects as my mental illness coming back. And so I've left their guidance. It's easy to understand why that happens. When people come into your office, your emergency department or your clinic and say, I feel awful, I'm having panic attacks, I can't sleep, I stopped my medication 2 weeks ago, it's easy to jump to the conclusion that this is a return of someone's condition, especially when guidelines have said for 2 decades these symptoms are mild and brief and someone comes in with severe, long-lasting symptoms. There's a few clues to distinguish, which I'll go through very briefly. Withdrawal symptoms tend to come on more quickly, but can be delayed. Specific symptoms like dizziness or allergic shocks are not part of anxiety or depression. Sometimes even new psychological symptoms are much more likely to be withdrawal than relapse. Often restarting the drug will make withdrawal symptoms go away fairly quickly. When people aren't aware of these symptoms, there are all sorts of misdiagnoses, chronic fatigue, neurological disorders, and other psychiatric disorders that are given to people. This is a quick table asking people, what symptoms did you have before you started medication? People were depressed, they were suicidal in some cases, and what did you have after stopping medication? And you can see there's a very big increase in how common these symptoms are. So although many of them were present beforehand, they're more severe and they're more common when you stop, showing that these are new onset symptoms caused by coming off the drug. And protracted withdrawal syndrome is very under-recognized. These are the people with months or years of symptoms, sometimes debilitating, often misdiagnosed by clinicians who are not aware that people can have trouble for long periods of time afterwards. So in the UK, to incite a bit of competition here, the UK updated its guidance based on this research now in the last few years. The Royal College of Psychiatrists went on national TV to tell the public that there are severe and long-lasting withdrawal effects from antidepressants. NICE, which is the government committee that puts out guidelines for doctors in the country, updated its guidance to say that symptoms can be severe and last longer. The guidance has not been updated in the same way in Australia, and most clinicians are still under the belief that most withdrawal effects are mild and brief, even for long-term users. So if that's the problem, I want to talk briefly about the solution, ways to avoid the issues people have coming off these drugs. I want to just briefly, there's a lot of research on why people who are on antidepressants or benzodiazepines for longer than they need to be stay on them. One of them is because they mistake withdrawal effects for needing to be on it. So they stop it, they say, I feel terrible, therefore I should stay on it. That's one reason. Another reason is that many people in the public believe they've got a chemical imbalance that they need the drug to fix. That has been messaging for the last 3 decades. And if you ask Australians, about 9 out of 10 people believe that depression is caused by a chemical imbalance that antidepressants can fix. That idea was originally a scientific hypothesis. It's been researched for 6 decades. And a summary of all the research is there is no difference between people, healthy volunteers, people with depression in their chemical balance. In fact, it's not even clear what is a correct chemical balance. It was a line that really originated from the marketing department of companies, because if you believe you've got a chemical imbalance, of course, you're very likely to want a chemical solution for that issue. The Royal College of Psychiatrists in the UK has said, that idea hasn't stacked up. They've taken it off their websites. And in fact, in the last few months, so has the Australian College of Psychiatrists. Doesn't say anymore that depression is caused by a chemical imbalance. There are other explanations around about how antidepressants might work. They might increase the growth of new neurons. They might affect inflammation. They may affect stress hormones. This is what I did a 4-year PhD in. I'll just pick on one of these ideas. All of these come from animal studies. They haven't been shown in humans. To take the explanation that's most commonly put forward these days is that antidepressants cause the growth of new neurons, new brain cells. It's not clear whether that is a good thing or a bad thing. Someone said to me after I finished my PhD, if you cut your skin, you get the growth of new skin cells as a response to damage. There are various things that cause the growth of new brain cells, things like stroke, like blunt trauma to the head, and like chemical toxins. So it's not clear whether the increase in the growth of new neurons in animal studies exposed to antidepressants is a sign of a positive effect or a sign of a repair mechanism to damage. So it's not quite clear what that means. What is clear is if you interview people who are on antidepressants, more than half, sometimes 3/4, say what they experience is emotional restriction, that their range of emotions from positive to negative is constricted into the middle. Now, if you're experiencing great panic and anxiety, having that turned down from a 10 to a 3 may be a relief. But it's also the number one reason people come to my clinic, where I help people stop antidepressants in London. They say, I don't know who I am anymore. I'm not sure what I think about my spouse. I used to have an interest in art and music, which I no longer have. So in the long term, these effects can be detrimental. In fact, emotional numbing correlates with genital numbing and the sexual side effects that are often reported with these drugs. And if you crush up many antidepressants, it'll actually numb your mouth. So I think there is a general anesthetic effect that comes from these drugs. That may be the way that they work. That is a very different explanation for how the drugs work than what people are told. So if you're told this drug will correct a chemical imbalance, you're very unlikely to stop it, which is what studies show. If you're told that this is a drug that may numb your emotions, you may have a very different relationship to the use of the drug. It's going to spend a few minutes talking about the guidance from the UK on how to safely stop antidepressants. Just give a brief outline. So this was published in 2020, and it gives a few broad broad principles for how to stop antidepressants. It says taper off over months or more than a year. Go down to very small doses, maybe less than 1 milligram for some patients. Go down in smaller and smaller size reductions and adjust the rate to the individual. Some of that might sound quite unfamiliar, and I'll explain where it came from. So we published a paper in the Lancet Psychiatry now 5 years ago, looking at the effect of drugs on the brain. And the key points in this graph are, this is dose of a common antidepressant on the x-axis, and the y-axis is effect on the brain. And the key point is it's not a straight line. So doubling the dose from 20 to 40 milligrams doesn't double the effect on the brain. And even a tiny dose, what might be called a homeopathic dose of 2 milligrams, actually has about half the effect of 60 milligrams. And the reason for that is the law of mass action. When there's not much drug in the system, all the receptors are open for business. And so every milligram of drug has a large effect, a bit like the game of musical chairs. At the beginning, it's easy to find a chair. When there's more and more drug in the system, more and more receptors are occupied, and every extra milligram of drug has less and less effect. And that shape is called a hyperbola, if you remember high school maths. That allows us to understand what happens when people follow the guidelines that are currently in Australia, which is to halve the drug, halve again, and stop it. When you go from 20 milligrams to 10 milligrams of citalopram, there's a small change in effect on the brain. Some people can feel that. Some people find it okay. And from 10 to 5 is a bigger change, can be unpleasant. But going from 5 to 0 is like jumping off a cliff. But it has about 15 times the effect of going from 20 to 15. And when clinicians are not aware of this relationship, they can see that they might think that people need the drug. The last few milligrams are particularly important. A more rational way of stopping these drugs would be to reduce by even amounts of effect on the brain rather than even amounts of effect on dose. And what that requires is going down by smaller and smaller amounts, down to very small final doses, so that that final dose before stopping is a tiny dose, so that the step down to 0 doesn't cause a larger change in effect than the previous steps. And that, because it follows the hyperbola, that's called hyperbolic tapering. That's now what the Royal College recommends in the UK, and also what the NICE guidelines in the UK recommend to all doctors. And they say that you should adjust the rate to the individual, because it's a bit hard to guess how everyone will respond to that. If people run into problems, pause or go back a few steps and then go more slowly. And some people can only reduce their dose at 10% of the most recent dose every month. In other words, the national guidance in the UK now is derived in part from those peer support forums, because they found that people could come off the drugs more easily, but that hasn't yet been put into place in Australia. The question is always asked here, how do you make up these tiny doses? Because the smallest tablets, for example, in the country are only 20 milligrams. There are a variety of different options with different costs and availability. You can cut up tablets with tablet cutters. There are some liquid versions of drugs available in Australia, such as for escitalopram. Many are not, but could be asked for. You can get compounded medications from compounded pharmacies, capsules, tablets, and liquids. Some people try to skip doses to try to make smaller doses by doing it every second day. But because these drugs often act very quickly, that causes very big ups and downs and cause people trouble. Switching to fluoxetine, which is a longer acting drug, can sometimes work, but it actually is not as easy to come off as the textbooks suggest. People can have significant problems coming off fluoxetine itself, so it may not be a free ride. In the UK, this is an NHS website explaining to people that they can crush up their tablets and mix it with water in order to give medications to children. This is another option people can use, and many patients do this off their own bat to get off their drugs by going down to smaller amounts. So we put together this textbook to give sort of step-by-step guidance to clinicians on how to reduce people's medications in a safe way, adjust it to the individual, and goes through every specific drug that's available in Australia and what tablets and what liquids to use at each step. Here are some examples of guides to coming off citalopram, a faster guide and a slower guide, people that have trouble. And the last thing I want to say is that everything I've just said about antidepressants is also true for every other psychiatric drug class. For benzodiazepines, for Z drugs, for gabapentinoids, for mood stabilizers, for antipsychotics, stimulants, and also for opioids. This relationship where dose has a hyperbolic relationship with effect on the brain, and so going down in smaller and smaller doses makes sense. And all of these drugs will cause withdrawal effect for the same reasons. The brain adapts to these drugs. When you stop them, it doesn't just go back to its normal state. It takes a while for it to reset. That's it. Next question.
Next.
Hello. Hi. Just quickly, just wanted to say thank you so much for that, Mark, and wanted to kind of introduce Rebecca Hoffman. We at the Commission are just so glad to be co-hosting this event with the RACGP New South Wales branch. And so hopefully we can see you online, Rebecca. You might not be able to see the live audience here, but we've got looks like 50 people online potentially at the moment, which is a great turnout. And Rebecca will be facilitating the panel and doing the next batch of introductions. Thank you.
Thanks so much. And I agree, it's lovely to have RACGP co-facilitating, as this is such an important aspect of what GPs do in everyday general practice. We've got a really incredible panel in front of us and online today, and I'm really excited to be able to introduce everyone. I'm a GP and a fellow of RACGP, and I'm currently the chair of New South Wales and the ACT faculty for RACGP. And I'm excited to introduce tonight's panel. So we have Professor Catherine Wallace, Main Professor and Head of the Main Academy of General Practice and Head of the General Practice Clinical Unity at the University of Queensland Medical School. She's a fellow of both the Australian College of Rural and Remote Medicine and the Royal New Zealand College of General Practice. Catherine is also a founding director of the practice-based research network UQGP Research and is currently practicing part-time as a GP on the Gold Coast. Welcome. Thanks, Catherine. Then after Catherine speaks, we'll have our next speaker, Dr. Karen Spielman. Karen is a GP who's worked in youth health for over 20 years in multiple settings, including most recently as clinical lead in GP at Headspace in Bondi Junction. She also serves as the primary care mental health advisor at the Inside Out Institute and holds the position of advocacy chair at the Australian Society of Psychological Medicine. And then our final panel member, and honestly the one I'm most excited about coming along tonight, is Anna King. So Anna is a registered nurse with lived experience of antidepressant withdrawal. She's a patient advocate and seeks to provide her perspective to both the public and the medical community. And she's a wife and a mum and comes up from Tasmania. So welcome to our whole panel. We look forward to hearing from everyone on the panel members. We'll hear from each of them in turn. I have told them that I'm an interrupter, so if there's questions that come through, I might interrupt and ask them as we go, if they're pertinent. Otherwise, online, we might leave them to the end if there's something that can wait till the end. And I'm going to start by inviting Professor Catherine Wallace to give us an overview of antidepressant prescribing in Australia and how to use the tapering protocol to deprescribe.
Thanks so much, Rebecca. If I could have my first slide up, I think it was going to happen your end. Otherwise, I can share my screen if you would rather. Do you want to put it in slideshow? doesn't matter. Okay, well, look, thanks so much for that kind introduction. I'm a GP, so it's lovely to be here as part of the New South Wales RACGP event and to be part of the New South Wales Mental Health Commission as well. So you can see from the slide that GPs in Australia prescribe 92% of antidepressants. So antidepressants, as Mark mentioned earlier, are by far and away the most commonly prescribed mental health related medication. And of those antidepressants, GPs are prescribing most of them. We published a paper in the AJGP drawing attention to this issue that was published in 2021. And Joanna Moncrief was one of the co-authors on that paper who put us in touch with Mark, who's now one of the co-investigators on our study. So next slide, please. Just looking at the increase in antidepressant use and how Australia is one of the highest users of antidepressants among OECD countries, it's largely made up of increasing sertraline and escitalopram. And you can see these data for the 9 years to 2021 showing that sertraline and escitalopram have increased dramatically, and in comparison to another similar country in Netherlands, who've managed to keep their prescribing rates down. But in Australia now, sertraline and escitalopram are among the top 10 medications prescribed. So in response to this issue, next slide please, we secured some funding from the Medical Research Future Fund and the National Health and Medical Research Council. Next slide please. Would you rather I shared my screen and did it? So we received funding to conduct a trial in general practice to test a brief intervention that we've developed, which is the Release 3A's brief intervention designed to prompt and support safe cessation of antidepressants, long-term antidepressants in general practice. So the 3A's are ask, advise, assist, and we say that GPs can use this intervention when they're seeing patients in their practice requesting a repeat of their medication. So you would ask the patient, how long have you been taking antidepressants? Have you ever tried to stop? Often people have had an experience in the past when they've tried to stop and quite an unpleasant experience if they've experienced withdrawal symptoms. And then advise patients that long-term use of antidepressants is not harmless. People often think, you know, why rock the boat? They're pretty harmless, there's no problems. But there are adverse effects associated with long-term use of antidepressants. Also advise patients that long-term use is not recommended. Clinical guidelines usually recommend 6 to 12 months therapy for an episode of major depression. Advise people as well that depression is not a long-term condition caused by a chemical imbalance in the brain. And also advise people about withdrawal symptoms and that withdrawal is not relapse. And then assist people by providing a tapering protocol that we've developed based on Mark's tapering schedules that provide practical step-by-step guidance for decreasing antidepressant dose in a hyperbolic manner, and then instructions on how to access the drug mini doses. Next slide, please. And so this is an example of the tapering protocols that we've developed for sertraline, and you'll see that there's a faster version, a slower version, and an even slower version that patients can choose. And we would recommend, you know, the even slower version if somebody, for example, has been on the sertraline for a very long period of time or has had previous bad experiences when they've tried to come off. You can see the little red arrow on the left there drawing attention to the second half of the tapering. So you start at the top, start on your current daily dose and take the steps down. in drug dose, and often people sort of go easily for the first half of the tapering schedule and then think this is a piece of cake and think I don't need to bother with this anymore. But you can see if you get from 100 down to 10 milligrams, you're only halfway there. The hard bit is ahead. Next slide, please. And this is just a close-up of the tapering schedule. So there's advice at the start there to say aim for 2 to 4 weekly step downs, do not skip a day or alternate doses, and do not skip the final stages of the tapering schedule. That's the most important part, not to forget. Next slide, please. So we've had quite a few people approach us about getting access to these resources. And this is a patient that emailed me just last month saying she wanted to taper off her SSRI, and she was wanting me to suggest any Australian guidelines or official documents that she could provide to her GP to help persuade him to let her try tapering. She's on sertraline 100 milligrams and has been on that for almost 10 years. Prior to that, she was on paroxetine for almost 20 years. So I sent her the tapering protocols and advised her to take it along to discuss with her GP. And she said, oh, wow, this is an amazing thing, extremely helpful. My appointment is in 2 weeks, so I'll let you know how I get on. And she did get back to me after meeting with her GP and said that she saw her GP and he was open to hyperbolic tapering. He'd never heard of it before, but he was most interested in the tapering schedule. And he even ended up commenting that some people do have trouble weaning. So thanks again so much for your help. I'm much more at ease weaning at this slower pace. So that's an example, I think, demonstrating the need in the community, both from patients but also from GPs. Next slide, please. This next slide just shows the instructions that we provide at the bottom of the tapering protocol, how to make up the antidepressant mini doses that you require for tapering. For sertraline, we advise that people can crush the tablet and mix it with water and to use a syringe to draw up the mini doses required every day. So next slide, please. And we've conducted a Think Aloud study with people with lived experience of long-term antidepressant use, looking at the resources that we've developed, and feedback from one of our participants says that it takes a little bit of the fear away. It's really good to have an individual tapering protocol. You feel like it's more set for you rather than generic. So that was nice feedback. Next slide, please. So we've developed brochures as well. So there's one called Stopping Antidepressants, which provides information about the withdrawal symptoms and the tapering process and the rate of antidepressant use in Australia. Next slide, please. We've also developed next slide, please, a brochure for how family and friends can help, just explaining how the tapering process can be quite a challenging time and how family members can help, and feedback from our participants with lived experience. The fear of relapse, that was something that's mentioned in these brochures. That's definitely what resonates with me. That's the sole reason I'm still taking them. Next slide, please. Some other feedback that we got from our participants was, next slide, please. The difference between withdrawal and relapse, we set that out in the brochures, and they said that it hadn't really occurred to them, this information, so that was new information. This piece of feedback from one of our participants said that she wished she'd had that information. She could have done something. Her life could have been quite different. I've suffered these adverse effects: weight gain, low sex drive, inability to achieve orgasm, emotional numbing, fatigue, lack of motivation and sleep disturbance for the last 18 years. I only needed to go through that for 1 year. I wish I had that information. I wish I would not have been on them for so long. Somebody else said, I just thought once you're on them forever. And somebody else said, I'm blown away by the 1 in 7. So next slide, please. We've also developed a decision aid that sets out the pros and cons of continuing antidepressants or stopping antidepressants, and the process to help people have a discussion with their GPs and to decide whether they want to, embark on the stopping antidepressants process. Next slide, please. And our participants said that it was really nice to see the issue broken down into straightforward pros and cons type lists. She thought that was helpful, putting things into perspective, and it was a helpful resource to take to their GPs. It provided a lot of information for the discussion. Next slide, please. This is one of feedback from a participant who said that I wish that every GP and psychiatrist who's prescribing this drug had this amount of information and awareness. It would make life so much better for people who've been prescribed this drug and want to come off. Thanks. So next slide. I'd just like to acknowledge the team that I'm working with on this trial that's testing these resources in a cluster randomised controlled trial in 27 general practices in southeast Queensland. The participants who are participating in our study, the GPs and practices, and the funding from Main Bequest, Medical Research Future Fund, National Health Medical Research Council, and our partners and investigators, of whom Mark is one of the investigators on the trial. Next slide, please. So thanks to everyone who's listening, and if you would like to access the resources, if you're a GP and want to use these in your practice, you can scan the QR code there and log on to access the resources and use them in your practice. So thanks very much for your time.
Thank you so much, Catherine. And my question that I'm going to be starting with is, will these slides and that QR code be distributed to the online group so we can access those resources?
I'm very happy
Yes,
for
they will
that
be.
to happen. Yep.
Beautiful. Awesome. Thank you. Thank you so much for that talk. That was fantastic. And those resources look really amazing. And I look forward to actually jumping in and having a play with them and having a look at them online. Our next presenter we have is in the room with you. This is Dr. Karen Spielman, and she's going to discuss the role of the GP in translating these guidelines into clinical practice. So thank you.
Thanks, Beck. If you just give me a minute to check all the technology works. So the microphone's working, the slides there. Excellent. Is the pointer working? Yes. Can you see me if I do that? Is that okay? Right.
We don't have slides online.
Oh no. It's getting there. It's getting there.
Okay.
Wait. Okay. I thank you so much for asking me to be part of this really, really important conversation. I'm delighted to be here. And I was just thinking as I was sitting listening, what a beautiful example this is of the teamwork that we need to keep our communities healthy and happy, and working together with research, with lived experience, with primary care and with specialists and with our advocacy teams. I really wanted to acknowledge that because I think that's how things work much better. So my role today, I hope, if I've interpreted correctly, is just to have a bit of a conversation about how this works in practice and to share some of my experience. But what I've learned a little bit, I was saying to Anna, I do embrace this, I'm a bit of an angry old Karen in my old age, but I have become a little bit more active in advocacy lately. And it seems a bit crazy, but I think a lot of people actually don't know what GPs do and what GPs can do. And GPs are very different. So I wanted to just start by saying, what do GPs do in this space? And I wanted to share a couple of things that you may think about when you think of what do GPs do in this space of depression, distress, mental health, mental well-being. Our recently year one before ex-RACG president, Professor Karen Price, talks about general practice as one long consultation. We get to know our patients over many, many years, and we get our therapeutic relationship exists from the beginning all the way through. And although we may have quick appointments and we may have long appointments, but essentially our relationship is one non-consultation. One of my beautiful colleagues, who's actually co-investigator on the release study, Dr. Johanna Lynch, talks about our role as holding the complex whole. And I think that this is a good example of that too, that medication is one part of complexity for people. And our job is often to partner with our patients to look at that whole picture and help to see the whole. Some people talk about GPs as the backbone of the system. When I was thinking about this earlier, I was feeling a little bit old and osteoporotic. I think we've been a little bit under a fair bit of stress in the last few years, so we're maybe not as strong as a backbone as we could be, but perhaps we should be, because a strong central primary care field really does make the whole system work better. Some people refer to us as jack of all trades, but masters of none. And identify with that sometimes. And then a lot of people will talk offhand, I'm just going to the GP for a certificate or a script, or because I need a medical certificate, or this new term, which I've learned over the last few years on our GP Facebook groups, which is go and get a note from your doctor, Ganafid. So that's kind of how we're seen. But my quote, which I'd like to add to this, is that GPs are as diverse as their patients, and I'll get to that in a moment. I see GPs very much as existing at the interface of mind and body, and we have a lot of colleagues that we work with who are generalists, for example, pediatricians and geriatricians, and us as GPs very much exist at the interface of mind and body. More than most, with all due respect to other what we call specialists, some people unkindly call partialists, but we very much see the whole person and exist at the interface of mind and body. And just a few statistics that my colleagues shared before. GPs prescribe 92% of antidepressants, but did you know that about 30% of all presentations to GPs are mental health? I've heard it's higher. And it's certainly higher for females, and it's certainly probably higher for part-time females. And interestingly, GPs actually deliver 80% of the Medicare mental health services. And I think that's a huge underrepresentation, because I don't know about my colleagues, but I don't actually use the mental health item numbers very frequently. So I suspect it's a lot higher. So you'll see at the top, that's us, general practitioners, using Medicare mental health services, and coming down the side there, other psychologists, clinical psychologists, psychiatrists, and other allied health practitioners. I don't know if anybody's surprised by that statistic. And just as a little corollary, GP is 5% of the health budget. I'll leave that with you. So all GPs are different. This was a terrific study. I referenced it at the bottom of the previous slide, done by the GP Mental Health Collaboration, GP MHSC. And you can see that not all GPs actually like doing so-called mental health. For 17%, it's outside the comfort zone. But for 22% of us, we're interested, engaged, and resilient, which means we feel like we do it well. There's another 32% who are interested, engaged, but drained by the work, which we'll come to why that might be a little bit later. So I think it's really, really important that you find the GP that works best for you. So I like to say GPs are as diverse as their patients. And a fantastic mental health nurse that I work closely with gave me the shoe analogy. You need to find the right shoe for what you're going to do. So how do you know how to find the right GP? You might need to ask around. You need to look at where they practice, how they practice. And there are some of us who might advertise that we are special interest mental health GPs. So it's really important to find the right GP if you're wanting to look at deprescribing or even prescribing, of course. I wanted you to know that when we prescribe, it's interesting. I hear conversations about people go to the GP for this, and they gave me a script. But I wanted you to know that when we prescribe, we've already looked at a whole lot of these other things as well. So we're working in that whole one long consultation. We know, hopefully, the context. We have already looked at comorbidities. We've looked at early intervention. We've looked at, we've been doing psychoeducation. We've looked at other alternatives. So it exists in that context that we're looking at prescribing and therefore deprescribing. And so I really encourage and advocate for people to talk about finding a GP that they feel comfortable doing this whole thing with, rather than just going for a script. I hope that makes sense. So that's the background. This is just a few points that I wanted to cover, but it's a conversation, so please jump in if you wanted to comment. So Mark and Catherine have gone through so beautifully this really, really important work. When you're in the consultation with your GP, these are kinds of some of the things that as GPs we might be thinking about. I think it's important for us to stay calm and not be reactive, to remain very patient-centered, and to be very clear about what's happening for our patients at this particular point in time. We need to be really careful when somebody's asking, and I think this goes for prescribing and for deprescribing, be careful to select the patients, to work out what else is happening for them. Is this the right time? Do they have the scaffolding? I talk about scaffolding a bit further down. So medication is only one part of the treatment that your GP should be either giving or facilitating for you. So when we're ready to deprescribe, we need to know that everything else is in place so that you can be really well supported to make this as smooth and as effective as possible. So we're asking, why are we deprescribing now? It's like Catherine's ask, assess and advise. One of the things that we can do to make it easier for you is to be talking about it right from the beginning when we prescribe, to insinuate that there will be a deprescribing process that we do as a partnership, looking at when it is the right time. And so putting that on the table already from the beginning, that this is part of the process. And that we should be, every time we're writing a prescription, just like antihypertensives or osteoporosis drugs, we're checking if we're on the right dose, we're doing the right thing, is the medication working? So this is all really important to be aware of at every point. What else have I got there? Review often and preparing carefully. And again, Mark's talked about that as well. That it's not as easy as just stopping, that we might need to be checking access to medications. And relapse prevention, of course, is a really important part of the conversation when we're deprescribing, checking that people know that it's completely fine to come back and have a conversation if it's not the right time, if it's not working, and how we know, like, what is the conversation about how to come back, and that it's completely fine to do that if needs be. Did anybody want to make any comments at that point, or will I just keep going and leave questions till a bit later? Yeah. I just wanted to cover what some of the barriers might be for this going really well. And I think barriers are at all levels. So the barriers might be at our patient level in terms of whether it is the right time, whether there is enough support in place. And when I was talking about reactivity as well, whether it's been considered that this is the right time to prescribe or deprescribe. I think we've alluded to in Catherine's last case history that there are a lot of barriers at the doctor level as well, that we aren't educated necessarily, and this is a really, really important job for us as a team to be educating our colleagues. So there are huge barriers there as well, and I think that can be a little bit mitigated if you are active in finding a GP that you feel confident to have this conversation with. And lastly, but definitely not leastly, especially in my Angry Karen role, is the system level barriers, which I think are really, really huge. And the biggest one, of course, is time. It takes properly, and I don't think our system is really well set up at the moment for us as practitioners to take the time that we need. Some of us choose to do that despite the barriers, but not everybody can. And I think that's a really, really important conversation for us to have as mental health advocates. I will come to that, a bit more of a conversation about the barriers in a moment, but I wanted to I was reflecting, Mark and Catherine, since you did the public launch 3 months ago with, I think it was more than 3 months ago, March, with ASPM, I was just thinking back, what are the actual changes in my practice? And I do largely work in this space now. And I really feel that since the launch of the guidelines, there is already more awareness in patients and colleagues, and certainly myself, in the subtleties and the differences with how people actually manage the process of deprescribing. And if I think back over the years, not embarrassed to say the harm that has been done by the process, certainly in my own practice, of not knowing the subtleties so much. So I think I'm much more aware of how my patients may have struggled in the past with deprescribing, and I'm really grateful to have learnt more about that. Since then already, I raise it earlier and more often with my patients, and I'm very much more active about highlighting the difference between withdrawal and relapse. And I think I've known that intuitively for a long time, or from experience for a long time, but I've been given the confidence to really speak about it very confidently, and that's been really useful. And of course, I think I've also learned in the last few months listening to these discussions to really go a lot more slowly, particularly the tapering towards the end. Some people do fine, and there are people that don't do fine, but being able to speak about it really confidently and have the conversation in the room has been really, really useful. So thanks, guys. And just lastly, some thoughts on the system. A bit of a crazy out there idea. I think putting GPs back at the centre of mental health will be really useful. We do tend to want to have special input, which is perfectly fine. But this is bread and butter for GPs, and Beck alluded to that at the beginning. We do this all the time, all day long, and we don't actually get recognised for it all that much. But like you saw, we do like more than 80% of Medicare mental health services, and it's well over 50%, I think, of the work that we do. And of course, we do not separate mind and body. And so we are talking about mental health, wellbeing issues all day long. So recognising that this is bread and butter for GPs, I think, is really important in terms of service provision. And it does take time. So at the moment, our system is such that that patients' rebates are higher with shorter consultations. I'm very grateful to whoever decided that we were going to have level E consultation rebates. I don't know if everybody knows about that, but with the GP rebates, they're time-based. And just since July, we've got a level E, which is over an hour. And I know my patients are incredibly grateful for a slightly better rebate for really long consultations. But that's really difficult for GPs. And don't get me started, or do if you want. But that's a really big problem, that this system really rewards quick medicine, and this is not quick medicine. The other point to make is that we actually love getting people off medication as a profession. We know, like for example, with our elderly patients, that the more prescriptions that people are on, the more dangerous it is. So we're looking at how to get people off medication all the time, and we know how to do it. So this is another sort of string to our bow to add with some really important ways to help people to get off medication. And I just also wanted to put a little, a big emphasis on depathologizing distress and de-diagnosing and taking labels off people. We can have a longer conversation about that, but I very firmly believe that mental health is not about what's wrong with you, it's what has happened or has not happened to you, and medication doesn't always fix that. It can make it worse depending on how it's managed. So I just think that's a really important part, not to lose sight of that as part of the conversation. And did I mention putting GPs back in the center of the system? Not sure if I said that. I think that is my last slide. Yes, thank you very much. Thank you for this.
I don't know if you could see me cheering in the background, but I was absolutely cheering in the background. Thank you so much for everything you said. Absolutely resonates with you, from GPs and female GPs carrying a really significant mental health care load. And that's because we love it and we see value in that space. And we do longitudinal patient-based care from cradle to grave. And this is such a big, important aspect of that. Just everything you said was absolutely wonderful, and thank you. But I have 1,000,001 questions, but we need to pass on to the next really exciting person we have presenting in the room today. So our lived experience panel member. So thank you for coming along today. And I'd really like to just quickly pass over to you. You're welcome to sit, you're welcome to stand, you're welcome to be wherever you need to be, but happy to introduce Anna King, who will share her personal experience of lived experience of deprescribing of antidepressants, what it looks like, what it feels like, and really importantly, how we can do it better. So thank you.
Okay. Thank you, Rebecca. Hello, everyone, and I really appreciate the opportunity to speak to you all tonight. My lived experience of antidepressant withdrawal is an example of what can go wrong when an antidepressant is deprescribed abruptly, and then the symptoms of antidepressant withdrawal are misdiagnosed as relapse with far-reaching consequences. Antidepressant withdrawal has caused profound suffering, disability and losses in my life. I was not informed of these risks. In 2006, I was prescribed my first antidepressant by a psychiatrist. I was experiencing distress and trauma from significant life difficulties associated with the family court system. My distress and despair met the criteria for a diagnosis of clinical depression and anxiety. I was hesitant about taking an antidepressant and sought information from my psychiatrist about their safety. I was told that they were safe and could be stopped at any time, if only I had known then what I know now. The challenges in my life that had led me to take antidepressants had eased significantly by 2015. But my mental and physical health had continued to decline. I became suspicious that antidepressants were the cause. I decided to cease my antidepressant due to their ineffectiveness and their significant adverse effects. I lost loss of libido, weight gain and fatigue being my primary concerns. In consultation with my psychiatrist, citalopram was ceased over 10 days. The resulting symptoms were devastating, and I was unable to function, let alone return to work as a registered nurse. Over the months that followed, I developed debilitating physical, cognitive, and psychological withdrawal symptoms, some of which included head pressure and pain, dizziness, nausea, fatigue, sensitivity to light and sound, irritability, cognitive difficulties, agitation, suicidal ideation, and terror and panic, which was so debilitating, I was scared to leave my house. Prior to taking antidepressants, the only symptoms I had were of depression and anxiety. However, now I faced a barrage of symptoms that were much more severe. I had never been suicidal prior to taking an antidepressant. These protracted withdrawal symptoms were misdiagnosed as relapse by my psychiatrist. And despite my reservations that withdrawal may have been the cause, but I continued to trust in their expertise. The physical withdrawal symptoms were hypothesised by my doctors to be due to another cause. This misdiagnosis resulted in a prescription cascade and ECT, both of which caused significant harm and disability. Over many months, I was prescribed over 14 different psychotropics. This polypharmacy led to a multitude of adverse drug reactions and drug interactions. I then experienced repeated rapid deprescribing, including antidepressants and benzodiazepines, which led to a catastrophic, protracted withdrawal injury. Some of these symptoms included severe akathisia, tremors, burning skin, bone aching fatigue, intolerance to light, sound and touch. I barely slept and I was housebound with no quality of life. The terror I experienced during these years was so profound, I felt like I was being suffocated by my own skin. Yet I could not escape. I was trapped in a chemical prison that my psychiatrist was unable to grasp, nor were they able to help me escape the prison safely. My treatment was not going well, but I rationalised this by thinking perhaps I was just unlucky. However, by the end of 2017, as I had lost all faith in my psychiatrists, I started searching for information online. I was desperate, terribly unwell and frightened. I found a peer support website called Surviving Antidepressants. There I discovered that my experience was far from unique. I wasn't alone, which in one way was quite comforting, but also unsettling as I became aware of the sheer number of people suffering harm from antidepressant withdrawal. Thousands of members from all walks of life shared their experiences of following their doctor's rapid tapering advice with dire consequences. This is where I first learnt the concept of hyperbolic tapering. I commenced the painfully slow journey of recovery through implementing hyperbolic tapering through support from strangers online. There was no medical support. GPs looked at me with absolute disbelief or blank stares. I have been judged, scoffed at, and belittled by various medical professionals. However, I have come a long way and my health continues to improve. But out of necessity, it is needed to be a slow process. I'm currently still tapering fluoxetine, my only remaining psychotropic prescription. I make my own suspension and I use a micropipette for accurate measurements. Hyperbolic tapering has mitigated my acute antidepressant withdrawal symptoms in terms of reducing the number of symptoms, their intensity, and their duration, to such a point that I can be here and speak to you all tonight. I often reflect on how different the past 9 years of my life would have been if this had been implemented by my psychiatrist in the first instance. So much pain and suffering could have been avoided, would have been avoided. I believe that the tedium of hyperbolic tapering is a small price to pay to avoid disability. A harm reduction approach is essential. No one should feel alone and unsupported during this process, but until medicine catches up, knowledge will not filter through to the broader community, and sufferers will likely not be believed by family, friends and colleagues. The losses cannot be underestimated. Loss of health, relationships, employment and reputation, just to name a few. And these experiences can have a profound effect on sufferers and lead to new challenges such as isolation and financial insecurity. My hope is that 1 in 7 Australians who take an antidepressant can be given the information and support that I did not receive from my doctors. Current practice is failing patients, and change is needed to ensure that medical professionals are trained to guide and support patients to utilise hyperbolic tapering principles. It is also essential to protect those who have not yet taken an antidepressant. Future consumers must be fully informed of the adverse effects of antidepressants and the difficulties they may face in ceasing their use. And only then can they give true informed consent. Thank you.
Thank you so very much for your words. And I think we all have so much to learn from you, not only for deprescribing, but also for prescribing. And those words I hope that we can reflect on and think about as we move forward. I want to take a leap back and just say, I think the point that I will be moving forward with my patients when I talk about how to deprescribe is the discussion around musical chairs. I absolutely love that as a concept, and as someone who looks after a large number of young people, I think being able to sit there and explain how we start with lots of chairs and move down to less and less and less, even down to how battered and bruised you get when you get to that single chair at the end, is such a fantastic analogy for this deprescribing that I will absolutely be taking that and stealing that as an analogy to use for my own. So thank you very much for that. We have a couple of questions online, but I just wanted to flick to the room to see if there was anyone in the room that wanted to ask first. Or I'll jump to the online questions.
Quite a few in the room, so I'll just...
Please.
Hi, my name's Gilda Brunello. I'm a GP. I work in youth mental health and have worked in general practice for a long time. And I've got a few comments rather than questions. The first is, when I have had experience with people coming off antidepressants, they have told me this story over and over again. And I was, I'm so pleased the science caught up with the education our patients give us, because I often sat there and got advice from the specialists on how to do it, and that just was not working. And so the patient and I would decide to slow it right down and do it at their pace. And I think that my point here really is our patients teach us before science teaches us. And we really should sit and listen to them. And when you say go at their speed, sometimes that's really, we have to go against the advice and go with what our patients are telling us. So, I feel very happy that things my patients and I have been doing for a long time, I now can have the science behind it. So thank you for doing that for us. Really appreciate it.
Hey, I'm just another mother who's helping her child deprescribe. Started a Facebook group called SSRI's Tapering Support Australia, and I just wanted to ask whether there is any future plans for Outro Health Australia, and whether that's the tapering support app that's available in Canada and the US, and if there's also plans to include like the police force in education about people deprescribing, because I find that they get a lot of call outs for people in distress who are, you know, having issues with, you know, when they're in distress, and they get a lot of call outs, and they don't ask the right questions, and that, you know, people end up in the ED rather than them having a better understanding of the situation. Yeah, they're my two questions.
So I'll answer a couple of those. Outro is a clinic I set up in America. I hope, actually, contrary to that, that in Australia, what will happen is more GPs, more psychiatrists will understand about withdrawal effects, be able to spot them, be able to help people safely come off them. I think that comes down to embedding this sort of information in GP, in medical school, in nursing school, in ongoing education for GPs and psychiatrists, and that the whole system needs to be involved. And I agree with you that at the pointy end of thing, you know, in the emergency department with police, people need to be aware that withdrawal effects from these drugs can cause severe presentations, people being suicidal, people being agitated, having akathisia. I get endless emails from people in Australia saying, came off my medications, I ended up in the sort of state that Anna ended up in. I turned up to the emergency department and they said, drugs can't cause this. You must have become psychotic or manic, and here's a bunch of medications, exactly like Anna's story. So I think people might hear Anna's story and think, that sounds pretty severe, but I have dozens of emails every week from Australians with exactly the same story, to the point where it's a sort of barrage. It's just so common because there is so little education about the trouble coming off these drugs. So I think it's a whole system approach that needs to be done, from who is being prescribed these drugs, for how long they're being prescribed, what does the plan look like to stop it, if people get into trouble, what is available for them, so that there's help all the way through. You know, we've seen so many things develop for long COVID or other mental health problems, but this is a completely silent issue that's being dealt with online. And the other reason it's a silent issue is someone like Anna's psychiatrist has written down in their notes, you know, terrible anxiety disorder or relapse of depression. And so that'll be registered by the government as, look, we have more anxiety and depression problems. We need more medication and more clinics. It hasn't been written down, this is a terrible withdrawal syndrome. And look, this high functioning nurse has lost 9 years of productive work, as well as personal relationships and life. That's not being counted up on the financial losses to these medications. So people are looking at, these cost $2 a month. You know, gee, that's a lot cheaper than therapy. Well, that's a lot cheaper than helping someone to find a better job. But if you don't tally up all the long-term effects, you know, unemployment, job loss, relationship problems, presentations to hospital, inpatient visits, electroconvulsive therapy, suddenly it's not looking so cheap, those $2 a month. I think the system needs to see that. At the moment, it's completely invisible, because as far as I know, I don't even think there's a diagnostic code that's used regularly for GPs to say this is a productive withdrawal syndrome. So I think the recognition of the system at the moment is about zero. And that's why there is no resources to help people get through these sort of issues. And the occasional enlightened GP sees the problem. I get emails from them as well saying, I've been doing this for a while, but there needs to be all GPs. It needs to not be that you got to choose the right GP. I mean, you don't get up here and say, oh, if you break a leg, you got to find the right orthopedic surgeon. I mean, that's to me, that's a ridiculous situation. It needs to be all doctors are aware of this issue, so it doesn't matter what door you walk through, you get the help you need. Otherwise, you know, we're living in a very selective society.
Well said.
Hi, my name's Dom. I'm not a doctor, I'm actually a lawyer, but I'm somebody who has suffered through withdrawals. I'm 10 months into a saga, and things are getting a heck of a lot better, which is why I'm able to be here tonight. I guess my real question is, it's so fantastic to see the science up on slides. My question is really, it's probably too big for a single answer. It's really this, what's happening here tonight is part of it, but it's about the pathway to change what's happening in the system now. To me, it seems that there's a number of issues. One is the warnings, which are in the official literature, which are just so woefully misleading and personally caused me harm. meant that I didn't understand what I was experiencing to be with withdrawals, because it didn't match up at all with what was on the literature. Changing the state of knowledge amongst GPs. Great to hear, let's put GPs back in the centre. I mean, they obviously already are, but unfortunately, I have to say, I've just had absolutely woeful advice from every GP I've been to. And I live in a part of Sydney which is well served by GPs, and I'm a well-educated person with lots of resources at my disposal, but had absolutely no idea what was going on for me. So yes, there needs to be massive change in that. And I guess as a lawyer, I sort of also think, well, at what point a GP is negligent by failing to pick this up? Because for the first time in my life, I found myself, I don't know how seriously suicidal I was, but certainly I understood what drove people to that point. And I haven't been able to work for months, and so on. So I mean, there's I'm sort of not a gung ho lawyer that likes to threaten suits and so on, but I guess I do think that at a certain point, if people aren't getting the message, that needs to be actionable. And so yeah, understanding what it takes to get the message out. To get this, if the science is not controversial, if the science is relatively well settled, then there just so clearly needs to be a major overhaul into how this issue is handled. Yeah, so that's sort of both a statement, but also a question about, what are the pathways? Somebody like myself would love to be part of any campaign there is to see this sped up. So great to sort of understand what role does the RACGP have in it, what role does the Mental Health Commission have, and so on. And what role do sort of patient advocacy have as well.
Okay. If I can just respond to a few of those points. So I agree that there needs to be changes at a variety of different levels. And you're right, starting with the TGA. So the drug regulators are responsible for emitting drugs onto the market and providing adequate warnings. There's lots of problems with the process. Number one is short-term studies. The drug's allowed to come onto the market, so people don't understand that mostly 97% of antidepressant studies go for 8 weeks or less. So we don't really know what happens to people who are on these drugs for years and decades because there are no such studies. The regulator doesn't require that a drug company shows that its drug can be stopped. But to me, it's the same as a car company being allowed to put cars on the road that don't have brakes. That's not a part of the regulation. You need to show that it beats placebo in 2 studies and that it meets a certain level of safety, but there's no requirement to show how the drug can be stopped, which is why liquids or smaller dose tablets of these drugs don't exist, because it's not a requirement. The warnings are inadequate because they don't look at long-term harm. So they say discontinuation symptoms, which is an industry euphemism for withdrawal effects to try to minimize negative publicity about these drugs. They don't talk about how severe they could be, that they can be debilitating for some people. They've only recently been forced by the TGA to put on that you can have sexual side effects that don't improve after stopping the drug, which is the right sexual dysfunction. So there's a lot of exaggeration of the beneficial effects and minimizing of the harms because of the short-term studies. It's interesting what you say about lawsuits, because this is a little bit of a repeat of a previous chapter in psychiatry, that this has happened before with benzodiazepines. So benzodiazepines were used as widely as antidepressants are now. They peaked, I think, at the same kind of levels in the country. And in the UK and Australia, what really made a big difference was class action lawsuits against the companies, against prescribers. It made prescribers nervous to prescribe. There was a lot more regulations put in, a lot more barriers, and it has led to a lot of reduction in prescribing, especially in the UK and in Australia. I think it's very unfortunate that that's what's required to change medical practice, but there is so much inertia in the system to have changes, because I think what this really needs is a college of physicians, psychiatrists and GPs to filter this information through to members as part of its core curricula, so that people who prescribe these drugs know the trouble that they can have when they stop them, and that's weighed into people's decisions, because I think you've used the word informed consent. I don't think anybody in the country has ever been given informed consent for these drugs. No one is aware of pretty marginal efficacy of the drugs, the issues with the long-term effects, the adverse effects, and the difficulty stopping it. So I don't think that many patients have really been given informed consent about these drugs, especially in long-term use.
I'm just going to jump in there and actually just promote that the RACGP has this month endorsed these guidelines. From the board level, has actually been guidelines that the RACGP will promote and will endorse, and will say, let's move forward with these guidelines, which is actually really exciting and something that's quite difficult to do. And so that really means that for the next generation of GPs in Australia, this is something.
In Townsville. Stuff up.
Can I pick up on it in the meantime?
Guideline.
Oh, you've got it.
Hold on.
We
No,
lost you
no,
back.
please pick up because my internet's a bit dodgy in Townsville.
Come back.
No, so I was just saying that we're really excited to then be able to teach this to the next generation of GPs. And we start with it being board endorsed, then let's get it down to all of our registrars and let's teach the next generation of GPs, not only deprescribing, but also prescribing, so we don't have these same issues moving forward. Can I ask a question from online, something a little bit more clinical if I can, as to what are the timelines for reducing? Is there such a thing as too slow? And how do you choose between medium and slow?
So it's very hard to put your finger on exactly how long someone should take. There's a few principles we outline in the book. There are risk factors. So the longer someone's on a drug, the more trouble they're likely to have. There are certain drugs that are harder to stop than others. SNRIs and paroxetine are harder than other antidepressants. People's past experience is an indicator to their future experience, and dose plays some role. So we have a risk calculator in there to assign people to either low, medium, or high risk, which gives you an idea. But really, what is important is monitoring how the person responds. So it's going at a rate that they can tolerate. A good rule of thumb to start slowly for people is to go down by 10% of their dose in a month, see how they respond to it, and based on that, make further reductions. People who are on the drugs for shorter periods of time, so people on them for a few weeks generally don't need these long sort of tapering processes. People who are on the drugs for more than several years most often do. And in long-term users, coming off between 9 months and 3 years, and sometimes even longer, is not unusual. Is there such a thing as too long? Look, you're guided by the person. If they say they're having no trouble, then it makes sense to speed up. If they're having trouble, you need to take that into account and slow down. The major side effect of taking too long is they're exposed to the drug for longer than they need to be. But sometimes the consequences of coming off too quickly are so catastrophic, it's worth going a bit slower. So in my view, it's better to start off slow and speed up, because if you speed up and get into trouble, it's sometimes not so easy to put the toothpaste back in the tube.
And I guess follow-up question is then, after prescribing, how soon do you discuss deprescribing? Do you discuss that in your first consult when you prescribe? How soon do you have the discussion about, okay, now let's stop this medication?
So in the UK, the guidelines from NICE and the Royal College of Psychiatrists say that this discussion should be part of deciding to start the drug. That you say, how long is this journey going to be? And it's too late to do it after you prescribe it. You want to be talking about. So in these guidelines, they say, what is it for? What does it aim to achieve? How will you know it's achieved that? When will you stop it? And how will you stop it? And what else will you do? So it's part of a holistic discussion where you're talking about the benefits of the drug, the adverse effects, the trouble stopping it, and the alternatives. And for example, in the UK, there are 21 treatments that are seen to be equally effective and cost-effective for depression, and only 3 of them involve antidepressants. So there are a whole variety of different treatments that are available. There's a very big social prescribing movement in the UK. There's much better access to therapy than there is in Australia, and there are all sorts of other options available that don't involve medications.
Thank you. That actually, I think, answered one of the questions about non-drug interventions as well. One of the other specific questions online was in regards to bipolar diagnoses, and specifically what your opinion was on the overdiagnosis or misdiagnosis of bipolar, particularly in regards to withdrawals then being seen as clinching that diagnosis when it might be a withdrawal symptom rather than a new or alternate diagnosis.
So I guess the way that that question intersects with this work is that there's a wide variety of withdrawal effects people can get from coming off antidepressants and benzodiazepines and other drugs. And sometimes that involves hypomanic or manic symptoms. So people can turn up and look manic, and people who are not aware that that can be a withdrawal effect can diagnose bipolarity. There's also been a discussion about bipolar 2 and even bipolar 3, where people who develop manic symptoms on antidepressants, it's said to be the drug revealing an underlying condition. There's a lot of controversy about that, whether really it's just a side effect of the drug rather than revealing something about the person. So I think the overall theme here is that there are a wide variety of adverse effects to these drugs, both from taking them and when stopping them, that can overlap with existing diagnostic categories for mental health problems. And people need to be really aware of where they can overlap so that unnecessary mental health diagnoses are not made.
And I guess on that, it's not only the de-prescribing of the medication, but also the de-identifying of diagnoses that may not exist for that patient or should never have existed for that patient as well. One of the question is quite clinical, and I'm going to touch on it anyway, but in regards to gene testing and CYP450 and effect of the decision of whether or not to use medications or not for people with that gene or otherwise, if you taper or prescribe differently based on that?
So the cytochrome P450 tests are telling you about the metabolism of the drug, whether you have enzymes that quickly or slowly metabolize the drug. It can give you some indication about whether you're going to have higher or lower levels. I think some people interpret this as saying this drug is not good and this drug is good, but it's really telling you just about the levels. It hasn't been shown to have very big predictive value in de-prescribing. And I think the main thing to focus on is the experience of the patient, the trouble they're having coming off, and using that to guide you rather than looking for some of these fancier technical aspects. I think the first thing is just to follow what the patient is telling you and what symptoms they're experiencing, and using that to guide how you're going about the de-prescribing process.
Thank you. And I think a really pertinent question asked, having listened to Anna, is actually the conversation around suicidal ideation. And something that we get discussed with as GPs is the increase in suicidal ideation when you start SSRIs, but it's not something that I've heard to this impact before about how it happens again when you de-prescribe. So there were a couple of questions online in regards to that around counselling, around accountability for that, around how we have these conversations with our patients.
Yeah, okay. Yeah. Well, when I realised what was happening to me and I wasn't having any support, I was in a very difficult situation because I had a protracted withdrawal injury, both from antidepressants, well, actually, the whole gamut, really. And I was very unwell, but I had no medical support and I wasn't believed. So I was suicidal, but I had to stay at home and deal with it on my own with my beautiful husband, because I don't know what I'd be without. Thank you, darling. And this is the other side of this situation that we don't see, is the support people behind people like me, who, because my husband didn't have any support either. So for me, I mean, this all needs to change. There needs to be an understanding, not just with GPs, but first responders. It needs to be in, the emergency departments and it's not seen as a mental illness. It's a response to mental illness. It's a response to a drug withdrawal problem, and this is what isn't understood. But I knew I had to keep myself safe, and this is really a terrible thing to say, but I had to keep myself safe because I knew if I put myself into the emergency department, I put myself at risk of being sectioned and drugged, and that would have made my life worse. So I suffered in silence.
I can just add to that, just to put some context to Anna's experience, awful experience. We surveyed 1,300 people that were coming off their antidepressants, and 3 out of 10 of them had been suicidal before they went on the drugs as part of what they were there for. When they came off the drugs, 6 out of 10 experienced suicidality. In other words, 3 out of 10 people had new onset suicidality because of coming off the drugs. Just think about how many people that is turning up to emergency departments. And a lot of them end up in Anna's position where they think, if I go to see a doctor, I'm going to get into more trouble. They're not going to see it's due to the drugs. They're going to say something terrible is happening and end up in hospital. I might be given more medications. So there is almost now a shadow medical system, people at home with supportive partners or friends looking after these people because the medical system is oblivious to these issues. I don't really have a good sense of how many people this affects every year. But if you think about all these people turning up to emergency departments or not seeking medical help, there is a huge hidden problem here from coming off these drugs.
Thank you. I think it's really important to touch on those really difficult conversations as well. There's a very specific question in regards to swapping from SSRI to SSRI, and if there's any benefit from swapping from one to another rather than maintaining the same drug and reducing dose on the same drug.
So there's a couple of things to say about that. There's a meta-analysis that looks at if someone doesn't respond to one drug, will they respond to a second drug? And 8 randomized controlled trials said no, there's no difference. So there's no good reason for swapping for efficacy. You're talking about swapping to make it easier to come off the drug, then people often suggest going to fluoxetine because it's easier to stop. I think there's a bit of misinformation from that because studies on short-term fluoxetine or Prozac show it's easy to stop, but longer term people have trouble, just like Anna. It's not a free ride, and sometimes the switching process is not so simple. So going from, although the SSRIs are from the same class, the receptor affinities can be somewhat quite distinct, and so it's not so simple to make the switch. So if there's no other option, it might be a possibility. But in general, in my clinic, we take people off the drug that they're on, that they're used to, rather than complicating things and stopping one drug, starting a second drug, and stopping the third drug. But I guess it is an option if there's no other ways to do it.
Really interesting. One of the questions, I guess, in relation to this, but I might group a few questions together, is how long into the taper do you notice that specific feelings change? So one of the specific ones is in regards to numbing, but also in regards to sexual function and suicidal thoughts as well.
So if I'm interpreting the question correctly, it sounds like they're asking maybe when does side effects from the drug improve? Because sexual side effects and emotional numbing are often a part of being on the drugs. And sometimes people find they need to get down to very low doses before those symptoms go away. What makes the situation complicated is some of those are also withdrawal symptoms, which makes things a bit complicated. So I've just talked about post-SSRI sexual dysfunction, which means that sometimes people can have this sexual dysfunction that they have on the drugs that continues even after they've stopped the drugs. And so sometimes there are these residual effects of the drugs that continue. And so it may be quite a while after people are off the drugs that they experience relief from some of these side effects. So it becomes quite complicated to differentiate side effects and withdrawal effects. I think I'm getting a subtle indication that things are being wrapped up, so I'll leave it there.
Amazing. I mean, I'm wondering what our call to action is going to be here tonight. So we'll talk about them. And I just want to first thank everyone who's come online. So online we've got Rebecca and Catherine, and then we've got Mark, Anna and Karen. And can we please, Anna, just have a round of applause, please, This is the human face, and I really feel like there is a call for action, and we might take that around the room in a sec, but there's other people to thank as well.
Yeah, look, this was a mammoth effort from the RACGP and also from the Commission staff. So a big thank you to Sarah Spagnati and also our Linda Proud and other Commission staff as well for all the work that's been done in the background. And we being able to do this together, I think really speaks to what you said, Karen. I think it takes lots of different parties coming together to create change. And I hope that this is something that we can build a bit of momentum around. We've got a couple of logistical things in terms of getting people to send their evaluation. So we'll actually send you guys a copy of the slides and also an evaluation form in the next couple of days. Yeah, and a link to the recording. So if you could fill in the evaluation, that'd be really helpful. Last call out for our RACGP members. If they want to get CPD for tonight, please send your name and your ID number in the chat so that we have a record of that. Otherwise, thank you so much for coming and coming all the way to our offices in the Commission. And
this is our first event right here, so it's very exciting to be this you know, impactful. It's really, I thought we could do a little chat here now, but we probably don't have the time. But, you know, what are things you're taking away from it?
Look, I think what I'm hearing are several systems issues. And there's obviously the clinician piece in relation to education and training from an education piece for medical providers and prescribers. But then there are these other systems issues in terms of where do we get some of our expertise in-house in Australia. I know that, Mark, you say you get 15 emails from Australians a day on this topic. Where is our expertise in-house within Australia? How do we develop that expertise? And when it comes to thinking a bit about compounding pharmacies and their role in being able to make up formulations that are smaller, there are implications there. And also in thinking a bit about the dosing of medications as well from a drug company perspective, another really interesting implication there as well. What about you, Deb?
I was going to say, is this a public health emergency? I mean, is this how far we need to go? And I think probably it is. And so, you know, what do we do when that happens? We need to take action to.
Yeah, I mean, 1 in 6 people are on these drugs. 1 in 4 have serious trouble. That's hundreds of thousands of people. It's a very big issue in my view.
And I think we just have to go back to the human element of it and the impact that this is causing on people, families, and systems. So, yeah, no, thank you so much. Really grateful for tonight. We'll hand over to the crew over there and we'll close today. So thank you very much, everyone, for coming.
Thank you.
Oh, fuck.
Sorry, I've got too much.